Hi students, this is me Dr. Atitipari once again, and I have come with a very interesting topic and a very important one in psychiatry, and this is about depression spectrum disorders, suicide, and electroconvulsive therapy. As always, my presentations are especially for USMLE, PLAB, and NCLEX preparing students, but at the same time, if you are in medical or nursing school, I believe that my presentation will be very, very helpful for you. So without any delay, let's proceed with the presentation, okay? Depression spectrum disorder. Out of this, major depressive disorder is we have to deal with this one. So when you're talking about major depressive disorder, we have to remember 9 of the symptoms summarized as SISCAPs. Okay, S stands for sleep disturbances, I stands for decreased interest. Okay, interest decreases in pleasurable activities, also called as anhedonia. G stands for guilt, feeling of guilt or feeling of worthlessness. E stands for energy decrease. C stands for concentration decrease. A stands for appetite changes or weight changes. P stands for psychomotor retardation or agitation, and S stands for suicidal ideation. So you have these 9 symptoms. Okay, out of these 9 symptoms, you must have at least 5 or more symptoms plus either depressed mood or loss of interest, that is anhedonia. So when these 2 criteria are fulfilled for greater than 2 weeks, then we call this major depressive disorder. Again, out of the 9 symptoms of SISCAPs, you must have at least 5 or more symptoms, plus you must have either one or both conditions of loss of interest in pleasurable activities or depressed mood. Okay, 2 conditions. And third is that these things must last for 2 or more than 2 weeks. Then we call this major depressive disorder. Okay, and one thing is important is that when you screen for when you think the patient has major depressive disorder, you must always ask for the previous history of mania or hypomania episodes, so that we can rule out bipolar disorder. The treatment is CBT, cognitive behavioral therapy, plus SSRIs. This is the first line of antidepressant, and alternative includes SNRIs, mirtazapine, bupropion, and ECT, ketamine. Okay, so for USMLE, major depressive disorder requires greater than one of the 2 core symptoms, that is depressed mood or anhedonia. Okay, this is we said it, plus 5 out of the 9 symptoms for greater than 2 weeks. Sometimes bereavement or the grief can meet major depressive disorder criteria, and then in that case we can say that. But again, the person might have only grief, but if you think that the person is too depressed, then you can always check for these 3 criteria of major depressive disorder, and if they meet, then we don't just call them that the patient is in grief. We can say that the patient is now in major depressive disorder. Okay, often depression occurs because there is significant loss or bereavement or natural disaster or disability, some tragic life stories that may lead to major depressive disorder in person. Okay, yes, but in any of the case, these 3 criteria of symptoms, weeks, and 1 out of 2, that is depressed mood or anhedonia, this must always be made whatever be the condition, whatever the scenarios, just to diagnose the person is having major depressive disorder. So this is very important. Now we'll move on to the next slide. Sometimes major depressive disorder can come with the psychotic features. Okay, so if major depressive disorder has hallucinations or delusions, then we call it major depressive disorder with psychotic features. Psychotic features here are always mood congruent. That means whenever there is depression symptoms, then if the person has psychotic symptoms with depression, then these depression and psychotic symptoms must always come together. However, if there is a difference, if in some patients there are depression and also the psychotic symptoms, and when the person is having psychotic symptoms, they don't have any depression for more than 2 weeks, then we take that as different conditions. Okay, so that more goes with the schizoaffective disorder. But since it is to diagnose as MDD with psychotic features, it has to be mood congruent. So always the depression symptoms must be together with the psychotic symptoms, and psychotic symptoms can be either hallucinations or delusions. Okay, and treatment is antidepressant plus and atypical antipsychotic. If the person has major depressive disorder with psychotic symptoms, then we can also use antipsychotics, atypical antipsychotics, or sometimes ECT, electroconvulsive therapy, is needed. Assimilative psychotic features in MDD are more congruent and occur only during MDD, key distinction from affective disorder where psychosis is perceived outside mood episodes. So in USMLE, there will be whole clinical picture, and in the end you have to diagnose the conditions. The options will be MDD with psychotic features and schizoaffective disorders. You have to differentiate it based on this information over here. Okay, and I hope you can do it now. Next is persistent depressive disorder, so also called as dysthymia. So often dysthymia is a condition which has two or more than two depressive symptoms lasting for 2 or more than 2 years, and if it is children, then that is greater than 1 year, with any remission for 2 or less than 2 months. This is persistent depressive disorder, also called as dysthymia. So we have read about major depressive disorder with psychotic features, and differentiate that with schizoaffective disorder, and the third one we did is persistent depressive disorder. Next is major depressive disorder with seasonal pattern and depression with atypical features. Okay, so we say the person is having major depressive disorder with seasonal pattern. Also previously it was just called seasonal affective disorder also. So in this case, the major depressive episodes occur only during a particular season, especially during winter, and that condition plus this major depressive disorder occurring in winter season or in particular season, that must happen for greater than 2 consecutive years. Okay, and in most cases you see that across the lifetime of a person. So when these criteria are met, then we say that the person is having major depressive disorder with seasonal pattern. Again, that major depressive disorder will be there, the diagnosis will be made, plus that will be specifically in particular season, especially in winter, and this criteria must be made for greater than 2 consecutive years. Okay, and sometimes that can be throughout the lifetime. So the treatment here includes standard MDD therapies, that is SNRI, CBT, plus light therapy. Okay, so again, in examinations you might have to take light therapy. Okay, especially in USMLE step 1. Next, fifth is depression with atypical features. This is one of the most common type of depression. So we read about different depression, right? MDD, major depressive disorder with psychotic features, dysthymia, major depressive disorder with seasonal pattern, and fifth one we are doing is major depressive disorder with atypical features, so also called as atypical depression. In this case, this is one of the most common one. Almost 40% of the depression is under this criteria category. So anywhere between 15 to 40%. So in major depressive disorder with atypical features, there will be mood reactivity. Okay, so the beginning will be like a person has all those depression symptoms, but sometimes when he is out with his friend, he is happy. So that is mood reactivity. So transient improvement in response to a positive event. So this is one of the most important features of depression with atypical features. Plus there is hypersomnia, the person keeps on sleeping, hyperphagia, the person eats a lot, and there is lead and paralysis. Okay, and plus rejection sensitivity. So when these criteria are fulfilled, then we say that the person has depression with atypical features, out of which mood reactivity is one of the most important one. And then also in examinations you see that the person is eating too much, is sleeping too much, is having lead and paralysis, and has rejection sensitivity. Then you say the diagnosis is depression with atypical features or atypical depression. Okay, here also the treatment is SSRIs and CBT are first line, and if nothing works, then we can go with MAO inhibitors. Next is the sixth one we are doing is peripartum mood disturbances. In this category we have to know that there is postpartum blues, next is major depressive disorder with peripartum onset, and next is postpartum psychosis. Let's tell them one by one. So postpartum blues, 50 to 85% there is incidence. So any lady, if 100 ladies give birth to the children, almost 50 to 85% of those ladies will have postpartum blues. Okay, and the onset is during pregnancy, it starts during pregnancy or within 4 weeks of delivery. Okay, and there is increased risk with history of mood disorders characterized by depressed affect, tearfulness, often crying, fatigue, and starting 2 to 3 days after delivery. It usually resolves within 2 weeks. Okay, so postpartum blues is a common in postpartum ladies. It often starts during the last days of pregnancy, and mostly especially after 2 to 3 days of delivery, and it resolves within 2 weeks. And in this condition there will be depressed affect, depressed mood, tearfulness, and fatigue in the ladies, again the postpartum mothers. And here we don't need any drugs, we can only get the supported treatment. Okay, and we have to follow up to assess for possible major depressive disorder with peripartum onset, which now we are doing to deal with. So major depressive disorder with peripartum onset is 10 to 15% it has incident rate, formerly also called as postpartum depression, but we call now it is major depressive disorder with peripartum onset. It meets the criteria with onset during pregnancy or within 4 weeks after delivery. So during pregnancy or within 4 weeks, again, not 14 days. 14 days is for postpartum blues. For postpartum depression we go up to 4 weeks. So anywhere between during the last days of the pregnancy or within 4 weeks, that is within 1 month of delivery, if a mother meets the criteria of major depressive disorder, then we call it major depressive disorder with peripartum onset. Almost 10 to 15% of postpartum mothers go through this phase. Treatment is, we need to introduce here SSRIs. Okay, so CBT plus SSRI. Postpartum psychosis is, its incident rate is very low, that is 0.1 to 0.2%. It is characterized by mood congruent delusions, hallucinations, and thoughts of harming baby or self. So sometimes you also see these questions in examinations. Okay, risk factors include first pregnancy, family history, bipolar disorder, psychotic disorder, recent medication change, and here you need to hospitalize the mother, plus start with atypical antipsychotic. If insufficient, ECT is maybe required. Okay, if insufficient, ECT may be required. Here you have to remember that this question also frequently comes in examinations. So the mother will be they say that the mother after a delivery had some mood disorders initially, but then now she is trying to harm the baby, she's having hallucinations. So you have to understand this is postpartum psychosis. Now what do you do? Then you have to choose hospitalization and atypical antipsychotic as the treatment. Okay, sometimes we also go with ECT. USMLT, again postpartum blues 50 to 85%, supportive only, resolves within 2 weeks. Postpartum psychosis 0.1 to 0.2% of the postpartum lady, and emergency hospitalization is immediately necessary. Risk factor is first pregnancy and bipolar disorder, history of bipolar disorder. Now let's study about electroconvulsive therapy. So a rapid acting method to treat the refractory depression. If the person is not being held with 2 or more antidepressants, then we may go with electroconvulsive therapy. Then we said the condition is refractory depression, depression with psychotic symptoms, catatonia, acute suicidality. In these conditions we can go with ECT. In ECT, the person will go through tonic-clonic seizures under anesthesia and neuromuscular blockade. Okay, adverse effect is disorientation. Soon after the ECT, the person may have developed disorientation, headache, anterograde or retrograde amnesia, and these amnesias usually resolve in 6 months. Okay, safety profile, there is no absolute contraindication. It can be done even in pregnancy and in elderly. This is very important. ECT can be done even in pregnancy and elderly. Okay, USMLT, ECT is the fastest acting treatment for severe refractory depression. No absolute contraindication. Amnesia is the most tested side effect, usually resolves in 6 months, and it is safe in pregnancy. So for examinations, you have to remember that amnesia is the most tested side effect. Okay, so what is the most? They give the beginner, and you know that he or she is being treated with ECT, and they say which of these is the most common side effect, then you may go with amnesia. Also look for other options, and it is also safe in pregnancy. Now about suicide, risk factors for suicide death are we go with the mnemonic sad persons, so male sex. Okay, male are more prone to suicides, either young adult or older adult. They are vulnerable for suicide if the person has depression history, if there is the previous attempt of suicide. So this is the highest risk factor. This also comes in examinations. Okay, a person they will give all these options, and you have to choose which among them is the highest risk factor. Then we have to say previous attempt, history of previous attempt of suicide is the highest risk factor for current suicide or any future suicides. So again, ethanol or drug use, rational thinking loss, or if the person has psychosis, if the person has medical illness, then if the person has problem organized, or if the person has already organized the plan for suicide, then he or she is more prone to suicide. If there is no support spouse, or there is no social support, if the person has stated his future intent for suicide, then all these are the risk factors for really future suicide. Out of them, previous attempt is the highest risk factor. So there are something we have to remember for examinations point of view. If the most common method in the US for suicide is firearms, okay, shooting by self, and access to gun increases risk of suicide death, women attempt more but men die more. This is important, classic USMLE fact. Okay, the women, they attempt more and more suicide, but they do not die, and the male, they just die. So the men die more and women attempt more. Recent psychiatric hospitalization is another risk factors, and family history of suicidal death is also definitely another risk factor. Protective factor is having effective care, medical, familial or community connectedness, religious cultural beliefs, encouraging self-preservation, and if the person cognition is well developed, that he has problem-solving skills, then that is some of the protective factors. Again, USMLE previous suicide attempt is the single highest risk factor. Men die more with lethal arms, and women attempt more. Firearm is the most common method in US, and recent psychiatric discharge is also high risk period. Now after this, I have few of the USMLE practice questions for you. I want you to pause the video here if you are USMLE preparing students and deal with these questions. Okay, and here the answer is ECT, here the answer is immediate hospitalization and atypical antipsychotic, and here the answer is depression with atypical features. All these questions have been appeared in examinations. I mean similar vignette. Okay, not the same, but the similar type of questions where you have to choose these options. Next is English practice questions. I have also a few questions for English students. Please pause the video here and once go through these questions. I hope it will be very helpful for you. Here the option is temporary confusion and memory loss are common after ECT and usually improve over time. You might have to counsel this to your patients. Provide emotional support and reassurance, monitor for worsening symptoms. This might be another one. And reports a previous suicide attempt 6 months ago. So this can be the highest risk factor for suicidal death. Again, go through these questions. With this, I'd like to end my presentation here. I hope you got a very good revision of this topic, and I believe that you can solve any questions from depression or spectrum disorder in your examinations. See you in next video. Bye bye.